Good afternoon. I'm Rama Khalsa from Behavioral Health Concepts, and this is our third video on performance improvement projects, particularly focused on helping the drug MediCal organized delivery system counties get ready to do PIPs. And I'm very happy today to have Amy McCurry-Schwartz, our national expert on PIPs, here with us. And our topic for today is really looking at common mistakes and issues that can really trip you up when you're doing an improvement project. So we'll be walking through a lot of those and then look at an example of one that's in our PIP library. So why don't we get started?
Thanks, Rama. So let's just go over the common PIP mistakes that we're going to focus on today. And in the second slide that you have in your slide deck, you'll see this common PIP mistakes: lack of facts to support a problem, a lack of data that will support your position, and a lack of analysis of the problem. Analyzing existing data to identify targets, those kind of things are a common mistake that folks do when putting a PIP together. Also, having indicators or interventions that do not line up with what the identified problem is. So making sure that each of your indicators or interventions line up with that problem. So how would someone go about avoiding these common PIP mistakes? Identifying a problem area or opportunity for improvement in treatment or the process, but not taking it to the bank without first reviewing your facts and data. So that's the first thing we kind of want to talk about, is that to identify a problem and then decide automatically that this problem needs to be a performance improvement project. Right. That is something that we feel like we see a lot when we're reviewing these PIPs that the DMCs have submitted and that the mental health plans have submitted. So what we would ask is that when you're looking at putting a PIP together, that you include information from clients, consumers, families, staff, and community members, involving folks that might be at the hospitals for intake, involving folks at the sheriff's department or the court, wherever the clients might enter the system.
And there are a lot of different touch points for a lot of the DMC ODS programs because of the nature of the involvement that addiction often has with the court system. So we are anticipating that we'll see more of that, but it really is important to have a unique PIP team for each problem area, because those folks are invested and will help with the analysis and looking at the barriers and opportunities for improvement.
Right, and when we're looking at the clients, families, the community partners, they will help identify some of the barriers to better care. They would be able to be your subject matter experts on what is it in the system that might keep someone from getting to wellness and recovery. Why you want to ask them why they think the problem is happening. Then you can do some research and determine whether or not their thoughts are something that is truly part of the problem. And then you really want to ask them if they have ideas on how to fix it. I mean, I think that's one piece that's really missing a lot of times with these performance improvement projects, is that we're not asking the people on the front line, so to speak, how would they fix the problem? And they could really lend some of that expertise that folks may need for that.
And it is important to remember that all PIPs are supposed to benefit the clients that we're serving. And so having that feedback loop, even to the initial input on the problem and potential solutions and barriers, really helps you put the package together, knowing that at the end you'll make a difference in terms of the clients, which is the most important thing.
So once you talk to folks and you get their ideas and you have maybe some groundwork of what you want to look at, you need to do a thorough data review before beginning a PIP. This is something that we see a lot in the reviews that we've done. What happens is that a lot of times the PIP staff identify a problem, but they don't get down to the county specific level to identify exactly in their county what the issues are. So we need to, can't emphasize enough how much the review of local data that is linked to your particular challenge or problem is beneficial to the performance improvement project process. In addition, not only do you want to look at local data that links to the problem, that might tell you the percentage of folks who have the problem that you're looking at, but also when we're talking about county-specific data, we're talking about looking at the system procedures and processes that are unique to your particular county.
Right.
And we want to make a differentiation here and make it clear that the way something is processed in your county may not be the same way that it's processed in the county, 2 counties over, or even next door. So you need to look at that and think about how that process is unique in your county.
It is, and that's so important because depending on level of automation or even the size of a county, the processes can be very different, and you just can't leap to the conclusion that it's the same. So having that local data is really important.
And in addition to the local data, there is a lot of national data that is available as background, possible interventions, also as benchmarks, so that you can determine maybe there's a national average that you'd like to achieve for a particular problem. And some of those sources of data are listed on the slide that you see now. And I think, Rama, you could probably talk a little bit about more what those each do.
And many of the national data sources can be drilled down to your local jurisdiction. So some of them are SAMHSA, obviously, and NIDA, which is a funded organization that does research on quality and improvements for SAMHSA. NIMH, NIATEC does a lot of studies with local jurisdictions and shows many research trends. AHRQ is a national quality database, and NCQA ASAM, which of course all of us know in terms of addiction medicine. And then NASDA does have zip code and census tract level data. And especially if you have a large enough pool in your county, you should be able to see something that helps you say, oh, our data is actually higher than the national average or lower. And sometimes it's great to have these other sources so you have a good starting place, both in terms of the benchmarks as well as knowing where you stand relative to the national data related to these different indicators and different also interventions. Many of these sources also have evidence-based practices and interventions as well.
So setting up that solid foundation to identify the issues that lead to the problem is very important and something that we have seen missing from a lot of the PIPs that we have reviewed. If that data that we have mentioned is not available, you always can have a special survey or a focus group that would help you to understand the full extent of issues in your area and for that specific problem that you're wishing to tackle. So we think that when you look at and have a solid foundation, that indicators will flow from that.
Yeah.
If you have data that tells you how something has been measured in the past, then you will know what indicators you will need to measure in the future in order to see if there's been any change.
Yes.
So be sure to collect that baseline data for your indicators and identify effective and meaningful interventions that might mitigate the problem. So that kind of skips a little bit further to what we'll talk about toward the end, but I think that it's important that you realize that these are some of the common mistakes that we have seen as we've been looking at the PIPs we've been reviewing. So,
Right.
what are some of the best PIP concepts that we've seen, though? What have they done that have made them be the best?
And one thing we see is people have not only done a good job with their baseline analytics and analytics of the barriers of the problem, but they've looked a lot in their environment at all the potential influences, both positive and negative, on the problems. And they bring some of those stakeholders to the table as part of the team to try to make a difference with improving this problem area or making things better for the clients. And so that's really essential. And you see that in the really good PIPs. There's a broad view and then a narrowing down into good interventions and good indicators linked to that initial analysis.
And also, through that, they've developed a clear study question that is based on that data collection and analysis of the problem and what the potential causes could be. So that is another area that we've seen some of the best PIP concepts. So we want to now kind of ground you in what the source and impetus of performance improvement projects is. And performance improvement projects come from a Center for Medicaid and Medicare Services federal protocol that's required for us to follow in the delivery of services to both mental health clients and substance use clients in the state of California.
Right. So
in Protocol 3 of the OMB approved protocols, the validation of performance improvement projects is listed. And in that validation of performance improvement projects, there are 10 steps to validating a performance improvement project. And we have those listed here on the next slide for you. 1 through 5 are listed here. The first is to select a study topic. And of course, to select a study topic, you need to do research and determine whether or not that there's a problem in your area. And then the next one is to define a study question. Then you want to use a representative and generalizable study population, which means that you want to use a population that can be repeated, that can be, so if you choose to use your entire population, then obviously that's representative of your population. But if you choose to use a smaller subset, then it needs to be defined and something that can be generalized over the rest of the population. Then you want to select the study variables and use sampling techniques that are sound if necessary. So steps 6 through 10 include reliably collecting data, which we've kind of touched on, analyzing that data and interpreting the study results, and implementing interventions and improvement strategies, and then having a plan for real improvement. And the last is to achieve sustained improvement. And that's the overall goal of performance improvement projects. And that is that they will show an improvement for the consumer, the client, for the folks that you're trying to deliver services to. So that we want to keep that at the forefront, although that's number 10 on the list. It is everywhere throughout what we're looking to measure. So now let's talk about some key issues to remember when you're designing a PIP. So we've kind of touched on this a bit, but I don't think we can repeat this enough. That preparation and groundwork are keys to having a successful PIP. You need to train your staff on why the PIP is important, what you're doing, and what their role is. And some of the things here is that we want to talk about is that training is very important, but it's not in and of itself an intervention. So if you're setting up a PIP and you get to the point where you're trying to put in place an intervention and you have on your sheet of paper that training is your first intervention, Nope, that's not the PIP.
No.
Again, we want to bring the focus back to the fact that we're talking about the effect that they have on the client. And
Right.
training itself does not have that effect on the client. So once you put the training to use and
Right.
the folks are having, putting that into practice and they're delivering whatever services that you train them to deliver, then the intervention is in place.
So a couple examples of
Yes.
that are seeking safety, which is one of the evidence-based modules or programs that you can use for substance use disorders, and then the Matrix program for people with methamphetamine issues that UCLA helped develop. But training them is not an intervention. It's when they're doing the service and affecting the clients that you really started the intervention. So it's important to have that distinction. It's fine to have that listed on your flow chart as part of your to-do, but it isn't an intervention. It's a step, not an
Yes.
intervention.
So another key issue to remember is to create a baseline data set to measure against for improvement. Now, one of the reasons that we bring this particular instance up is that a lot of times we will get PIPs to look at and review where people don't have any data, they think there's a problem, but they haven't measured anything yet.
Yeah.
And having that baseline to determine whether or not you have improved is necessary and is, of course, needed in order for us to get to the level of an active PIP.
Yep.
And let's kind of step back from that, I guess. We kind of, in our previous videos that we've done, we defined the difference between an active PIP and a concept PIP. And in an active PIP, the number one steadfast criteria is that the interventions have begun. But in order to get to interventions, you have to have some data sets available, baseline data. So the goal and what is required in the state of California is that each DMC ODS or mental health plan have 2 active and ongoing PIPs when we come to do a site visit. So to have those active and ongoing PIPs, they need to have an intervention that is in place and is being started.
Right.
So another key issue is to measure similar time periods,
Yeah.
like a quarterly measurement, so you can understand the changes occurring because of the interventions. This is another area that I think is important for us to touch on, is that, we would like to have you measure at least on a quarterly basis.
Right.
If your data lends itself to be measured on a monthly basis, then, more power to you. Go for that. But if it seems like your data lends itself to be measured on less than a quarterly basis, you'd probably need to have a conversation with your quality reviewer about that. Because the reason we stress measuring data as frequently as quarterly is that in order to identify problems with your interventions, or to identify issues with data collection or even staffing turnover.
Mm-hmm.
If you wait to measure something until the 6-month period or the 12-month period, it'll be too late for you to try to fix some of those small fixes. So measuring quarterly would allow you to see those as soon as possible and make some changes.
And oftentimes during the ramp up, and usually there is a ramp up for a PIP, especially if you have multiple interventions, you can see some real aha moments where something you didn't anticipate is going on that's going to affect the result, and you still have time to auto-correct and make some refinements in those elements. And you don't want to spend all the time and effort and staff resources and then find out it's a mess. You want it earlier. If it's going to be a mess, you want to fix it quick and know quick, and you won't have that unless you have some good data collection and feedback loops.
That's right. So, and then the last thing on this particular slide we've already discussed, but a PIP is not active until one intervention has started. So I don't think we can say that one enough either, is that if
Yes.
the goal is to get to an active PIP, then there needs to be an intervention started, and we need to be at the point where we're going to measure whether or not that intervention was successful.
Right. Data collection should have started as well as the intervention.
Yes. Okay, so now let's talk about some specific PIP problems and what some solutions might be for those problems. We've touched on this a bit, in the idea of what some common mistakes are is that you don't have local data. So let's look at that problem and try to maybe talk about what a solution can be. So if there is no local data to show that an issue is a local problem, not just a national problem, what should we do? Because we know this is a problem for us. Well, maybe they need to develop a local source themselves. What could they do to develop a local source, Rama?
Well, some of the things I've seen happen that have been really productive is a particular clinic for youth is having a lot of problems with kids dropping out. And so having some of the children and families who've left treatment before it's recommended do a little survey with a staff person or aide or assistant who, even if it has to be collected through a series of home visits, is create a good survey tool and get out and collect some data. Because knowing why people leave treatment is essential. Therapeutic alliance is still considered one of the most important things for good outcomes. And when people are leaving treatment, that means something wasn't happening for them that they really wanted to happen, or they're unhappy with their therapist, or they're unhappy with the treatment. If you don't know, you can't fix it. So it's definitely worth doing those sampling visits or those data collection methods. And then also feel free to call us at BHC. We're spending a lot of time with a lot of the national and state databases that relate to substance use as well as mental health, and we may be able to help you related to brainstorming that issue.
And then also, a problem that we've identified is needing help to understand if your concept is a good concept for a PIP, and how do we go about, as the DMC, evaluating that. And again, I think this is an area where we can kind of throw out that we are available at BHC for technical assistance in this process. And on this slide, we've listed the phone number to call, but call your quality reviewer, talk to them about that, talk to them about the issues that you're having, or email them and let them know that you're trying to understand whether or not your idea is a good idea. And I think that you will be pleasantly surprised at the feedback that you will receive. Okay, so here's a couple more problems with some solutions. So the sampling approach that we want to use is not statistically sound and therefore creates a bias. So let's talk just a little bit about what some of that might mean, so that, because there might be some folks who are going, statistically sound, what is that? Bias, what is that? So when we kind of mentioned this at the beginning, but when you're looking at your population and you're trying to make it representative of your entire population, if you choose to do a project only on a small subset of that population, that could be sampling. If when you choose to pull the folks who you're going to give your treatment to, then you have to make sure that that particular set is either statistically sound or an entire subset of the population, meaning you could choose to deliver to everyone at a certain clinic site. That may not actually be sampling, but if you chose to only deliver to the third person who walked in on Wednesday, then that would be sampling. But would that particular sample, using that example of the third person who walked in on Wednesday, create a bias? And it might. You'd have to decide whether or not the people who show up to your clinic on Wednesday are the same people every week and this kind of things. But if you have an issue with whether or not your sample is statistically significant, sound, or creates a bias, then we would suggest again that you talk to your review staff or you use a professional with statistical background to get a consultation about what you plan to do. Some of you will have a professional with statistical background within your organization, and some of you will not. But one of the things that I have noticed while being in California is that we are not without many universities and places to reach out to determine these kind of things. So there is definitely folks that you could find to help you with statistical analysis.
And it really does help because, example, one sampling thing that I was involved in is the clinic was doing a youth program evaluation and they picked the month of July. Well, that's all well and good, but kids aren't in school in July, and so the data was skewed in some very unpredictable ways and didn't measure what the program was hoping because they didn't have a typical schedule that they have the whole rest of the year with the youth, and engagement with schools to treatment is a very common feeder, if you will, for both substance abuse and mental health services.
Right, so that's another way that statistically sound can have an impact. The next two problems that we've identified kind of go together. Yeah. The data plan is not clear to your staff, or the importance of the PIP activities are not understood by the stakeholders, so poor cooperation is happening with the data access. So these two kind of go together, and I think that the solution for a lot of these are communication.
Yeah.
So communicate, get training, get buy-in with your staff from the beginning. Make sure that you're letting them know how important it is that we measure the success of this performance improvement project. And then make sure that when you're involving stakeholders and you need their input, that the people who are obtaining that information, let them know the importance of that information and getting that information. And again, monitoring your data quality as you go along, having more frequent measurement dates of this kind of thing will help you identify if there is a problem with the particular data that you're looking at.
That is super important too when you're thinking about multiple people collecting data as part of a system flow. And one of the mistakes I've seen is people will train the clinical staff till the cows come home and they'll know what it means and why it's important, but they won't involve the clerical staff or sometimes even the data input staff. And so they'll not know that it's, what the importance is or why it's important, for example, not to leave fields empty. And so if you're not checking that, you won't know there's a problem until pretty far down the road. And so think system when you're doing your training, not just one little pocket of people who are involved in the program. And that'll make a big difference on data quality.
So the next problem that we've identified is that the interventions are not working. Can I, as the MHP or DMC, add a new intervention and extend the PIP? And the simple answer to this particular problem is yes.
Yes.
An additional intervention or a refined intervention based on what you've learned can definitely lend itself to extend a PIP. What we do ask when we put PIPs together is, though, if you're crossing into the next 12-month period, that there needs to be a new intervention. So just retooling one intervention won't get you to the next phase, but you'll need to put into place a new intervention that can be measured for that next 12 months. And again, that's just to keep up, make sure that the data is current, that we're not getting stale on what we're trying to do, that we're not putting all our eggs in one basket, I guess, is the best way to think about that.
That the one solution will fit all and last for a second year. And I recently did a review where a county had a real problem with people who were just released from acute care, making it to appointments, and they set up a wonderful system to meet the person in the hospital, arrange their transportation, assist them, and actually accompany them on their first visit. And then they helped with an orientation group. And the number of people making their appointments and having good hospital follow-up skyrocketed. And it was a very thoughtful, systemic approach to resolving a problem and really improving the care system, particularly when people were extra vulnerable.
The next problem that we have identified is that the data is displayed in a confusing fashion and or not shared with stakeholders. So I think that this is something that we often do. I think the expression for this is that we can't see the forest for the trees. We're too busy looking at what we're trying to do. We put together a chart or a table that makes sense to us.
Right.
But when we let others look at it, it may not make sense to them. So one of the solutions for this is obviously if you're going to put a table together or if you're going to put a graph together, or even when you write up your narrative about your performance improvement project, have somebody who has not been involved in the process look that over for you. I always say when I review these that I should be able to hand this particular performance improvement project narration to somebody on the street and they will understand what you're trying to do. They may not be able to do it themselves, but they will understand it. So, give it to, your significant other that doesn't work in the field and have them read through it. And then share that information with the stakeholders. Let the stakeholders know what has happened since you put an intervention into place. Let them know the effect of the PIP. Share that with the clients who have participated in your satisfaction survey. Share that with the people that answer the telephone and set the appointments up. Let them know how their efforts have improved or not improved a particular problem that you've identified. All right, so let's go through a few helpful tips that we've identified along the way that can, some tools, some tips, some things that can help you get in the right direction if you find yourself at a loss for how to do this. The first set of these tips we've kind of put as ways for the MHPs and DMCODS to work together. We're leveraging the fact that both these different entities are doing performance improvement projects. A lot of times these organizations are co-located.
Yes.
So why would we, reinvent the wheel for the people that are just down the hall, working on maybe slightly different issues than us, but having to have the same type of requirements. So the first one is use the performance improvement or PIP library that's available at EQRO.com. This website is the Behavioral Health Concepts website, and we have put out a PIP library by topic with a link to PIPs that look at quality, access, timeliness, or what's the last one? Consumer outcomes.
Outcomes.
Yeah. And so look at that particular PIP library to get some ideas. We've only put out there PIPs that were considered best practices. And I think it's important that we bring this up, and this is another thing I often say. There are no 100% awesome PIPs. It's one of those things that is got a little bit of gray. We can always improve. We are likely never going to get 100% of people to show up to their appointments 100% of the time, and we're not going to likely have a program where 100% of everyone becomes well and recovers and that's just not going to happen. So there's always a place for us to improve with performance improvement projects. So check out that PIP library for those. Also consult with county and BHC staff to adapt to any of your local challenges. There are likely folks who have been down this road before and can help you with that. We mentioned this already, but please consider getting outside help with using statistical significance tests if you don't have internal resources for those. It's necessary as showing statistical changes and showing that they're significant is necessary in order for us to be sure that the efforts we've put forward are actually making a difference. We don't want to go into a real detailed analysis of that, but we just want to folks to realize that the difference between a statistically significant difference and a difference. And sometimes what that will tell you is whether or not the change is because of what you have done or because of something that happened in your environment outside of what you were doing. So that is why it's important to look at that. Be sure to give your concept-only draft to your reviewer early on in the process so that they can help you avoid some of these issues.
And often there's some little thing that you could do to really strengthen the PIP and or the ease of your statistical process, or making sure in the long run it does benefit the client's outcomes. So, early is best, and feel free to make it a dialogue so that you can get it in good shape before you start your interventions.
So the next slide has helpful tips with resources to consider. The first one corresponds to the PIP library, where we talked about how there are PIPs on timeliness, access, no-shows, engagement of special populations in all areas of the state. So you can look at those. Make sure that you have data support so that you can accomplish your PIP, and pick a problem that program staff care about. I think this enhances their cooperation, and it lends to helping with the completeness of data. If they're invested in it, then they're more likely to do their best.
Yeah, and you see this a lot with counties where they have a good feedback loop to their PIP committee, and people do get invested, and if things are not improving as optimally as they would like, or they're worried about some other effect happening that's outside of their control, there's good dialogue and potential changes in the intervention. And so that investment part is really part of that whole culture of quality improvement that we're seeing counties work on to put in place, and really does make PIPs and problem solving in general more effective.
Next, we're going to go through a scenario where Rama and I are going to take a PIP that is available on our PIP library and show you specifically how that example relates to some of the issues and how they successfully accomplish some of the things that we have identified. But before we do that, we want to talk just briefly about the framework that we're under here. When we're looking at a performance improvement project, again, we have to go back to that federal protocol, Protocol 3, validating a performance improvement project. And the first thing that we need everyone to be concerned about and make sure that they do is that they start the process with an exploratory analysis. Verify, quantify, look at your problems, make sure that you have the information that you need to show there is an issue. Now, we're going to talk about indicators and we're going to talk about interventions. And indicators are the data that you measure your success by. Interventions are the actions that you do to impact the problem. So we're going to talk about both of those in this scenario. So be sure that you understand how indicators and interventions link together. We need to have an indicator that measures the effectiveness of your interventions. So if you have an intervention where you're going to call people to remind them of an appointment, then you need to make sure that you have an indicator that measures how often you reach a person on the other line. So you can't have an indicator that doesn't measure how effective your method of intervention is. In other words, if you're not reaching more than a third of the people every time that you call, then you need to look at some other type of intervention for that. Or you need to figure out, one scenario we discussed was maybe the person who's making the calls is only making them between 9 and 12 every morning.
Right.
And so they're not reaching people. Maybe those calls need to be made at a different time, but you're not going to know that if you don't realize that you need to have those two linked. So, and then be sure that they link back to the study question that you're looking at.
Right, and so as Amy was saying, if no-shows and lack of engagement are an issue, and you're testing text messaging as a way to kind of improve that, you need to know that all areas of your county or your DMC ODS actually has cell phone coverage. Otherwise, the text messaging will miss a whole bunch of people. So there's a lot of groundwork really that has to be done to really make sure the PIP and the indicators as well as the interventions all hang together and make sense logically and are aimed at, of course, improving the client outcomes.
Right. And as we've said many times, and I think we've said this in the last two videos that we did, don't make your PIP overly complex. Start small, and if you're successful, then bring that to scale. So start with one intervention. You know, if you're trying to effectuate whether or not people show up for an appointment,
Right.
start with making these phone calls.
Right.
Measure that for a while. If that doesn't get you to the goal that you'd like to receive, then let's roll out something else.
Right.
Let's add to that. But let's start small and roll that out. And you can start small with your intervention, or you could start small with your population. Just
Right.
remember that you want to make sure that what you're doing is going to affect more people and is going to be successful. And in order to do that, you should start small. All right, so in our scenario, we want to talk about the idea of continuous quality improvement. We want to talk about how it's necessary to assess, plan, and then put together your improvement techniques. So let's talk a little bit about how not to assess something. So you have a meeting and your staff are sitting around and someone raises their hand and says, I think we have an issue.
Right.
We have an issue with people not showing up for their appointments. And the response to that is, oh, okay, let's make that a PIP.
Yeah.
Okay, that's not how to assess something. Let's think about it this way. And I know we're making that quite simple, but I do think that sometimes we jump to the idea that we need to turn everything into a PIP, or maybe we just finished a PIP and we don't have a new one, so we want to jump to that. So I think what we want you to realize with assessing is that if you think there is an issue, then you need to ask yourself why. Why is there an issue? So, and if the response to that is, well, clinic X's patients' ANSA scores, you know, they don't seem to be improving.
Right.
Or I keep seeing the same patients back in 10 days after they've been discharged. Or Dr. Jones says people are never here for their scheduled appointments. Okay, so maybe you have an issue, but it's not a PIP yet. The PIP doesn't start there. You have to do the next step, which is assessing whether or not it's actually an issue. Ask yourself, do we have a way to measure that? You know, do we have the mechanism in place to determine whether or not Dr. Jones's patients are showing up? What data do we already have that could show us that? Are we already measuring no-show rates? We might be. And if we are, then let's pull that data and see whether it is in fact an issue, or is it just something that has been happening for the last maybe week or two, and it's
Or one or two staff members who are very passionate and articulate about their situation, but it doesn't represent all of the staff. It may be something unique in terms of when they work or their treatment style, or so you do have to dig. And just because someone's very passionate and articulate doesn't mean that they should drive the boat in terms of a PIP.
Sure.
It could be much, much more complicated, and it could be a very different problem than they think it is.
That's right. Do you know if the issue is out of whack with any similarly sized counties? Do you know if it's a national problem? Do you know if there are maybe national averages about this particular issue? So again, this is where you look at your data. This is where you start thinking, maybe it seems like a problem for us, but it's not. When we look at everybody else, we're doing just fine.
Yeah.
It's not really that big of an issue. Or when we look at everyone else, oh my goodness, look at how far off the mark we are. We have a lot of work to do. So is there a norm that you're not meeting? Is there something that's not happening? If that's defined somewhere, that'll help you set your targets. So that's something to keep in mind. So what we're getting at is that you need to define whether it's a problem for your county. And after looking at those questions and answering them, if the MHP or DMC feels there's an issue, then they have to establish a baseline measurement, which means you need to go get some data. You need to make sure that you can recreate that data after you put your intervention together, meaning that you can measure it the same way again. And you need to just see what the full import of that is. So we have an example here from one of our PIPs that are on the website. Data. In this particular example, there's quite a bit of data. And there is a problem. Actually, there's probably quite a few problems.
Right.
So in this particular example, they are measuring the timeliness of the delivery of services. They're measuring the timeliness from admission to the first face-to-face appointment, from admission to the first psychiatric or med appointment, from intake to the second face-to-face, and then from hospital discharge to the first psychiatric appointment or hospital discharge to the first face-to-face. And this data is sort of trends to the high end. They've got targets set here, and you'll see most of those if you look at this data a little bit more intently. Most of them are quite far from what their target is, and you can see some ups and downs in their data. But what this does is what they're trying to do here is really target where is the problem in our system? What are the issues that we can attack? You'll see on here that it's only taking 26 days on average for somebody from a hospital discharge to a first psychiatric appointment. And the goal is 30 days. So they're meeting that particular goal. But if you look at the admit to first face-to-face, that's 36 days. So what's happening different in those two scenarios? So that's what data can get you to. So after you get your data, you can formulate your study question. So in this particular PIP, they formulated a study question that was just creating a care coordination team with strategies to engage and provide timely access to outpatient services, increase engagement and mental health treatment, and increase overall client satisfaction. And although this is a nice study question, it's a measurable study question, it is one that is good in this instance because they're looking at so much data that they can generalize this over, each of those questions. This study question is also maybe a little bit vague in its writing, but it is something that gets you to where you need to go. So their intervention obviously is their biggest intervention is going to be creating this care coordination team. So what is this care coordination team going to do? And that gets us to the plan stage of our assess, plan, and improve. So in the plan stage, the MHP or DMC should gather input from stakeholders to explore solutions to the problem. What barriers are there? Can the MHP even have an effect on those barriers? Some examples of this include things where we've seen where an MHP may decide that they need to work on whether or not people are coming to their appointments. But when they go and they decide to ask people why they're not making it to the appointment, it might be because they can't make it because the appointment they're working during the day. Well, can the MHP affect that? Do they have later hours? They have a capacity to have those hours. So that's something to look at. Another example that Rama was talking about earlier involved, is the reason people aren't getting into their appointments on time or within a timely fashion, is it because we don't have available time slots?
Right.
Is it our staffing level just in general?
Capacity issue, yeah, that the network adequacy is just not there to really give people timely appointments, versus the issue of night hours, where some people who are working and wanting to maintain their employment need night or weekend hours. And this is actually one of the things in the standard terms and conditions of the drug MediCal waiver, is to look at the availability of night and weekend hours, and to support people who do want to maintain employment and various things. So you really do have to dig to figure out what are the barriers to that engagement, and make that part of your analysis and strategy. Otherwise, you could be completely missing the boat. You could add childcare, and no one has a childcare issue. You could, it's just really important to understand in depth what the issues are before you design your interventions.
That's right. So, and then how will you measure whether or not your intervention has had the effect that you want it to have?
Right.
So that's part of the planning stage. And still, not yet. A PIP has not started, not yet.
It's not active yet.
That's right. So the next couple of slides go through the indicators from our example from the PIP library. And in these indicators, they are looking at the timeliness to first face-to-face appointment. They've included the numerator and denominator, how they're defining those. They've included their baseline and then their goal. They're also looking at the timeliness to first outpatient psychiatric service, timeliness from their discharge to the face-to-face, and timeliness from discharge to the psychiatric medication appointment. They're also looking at no-shows and cancellation rates prior to that first appointment. So this is telling them prior to that first appointment who is not showing up. Is it, is there something in the system there that is causing folks to not make it to that? How many of them are canceling before they show up? Right. So we've set this appointment, but they're not showing up. So let's figure out what's going on with that. Additionally, they're looking at indicators for those that are referred to special services. Mm-hmm. The percent of clients that are hospitalized during the time while they're waiting for that first appointment. So they may have that appointment set up, but then they're readmitted.
Right.
And then they also plan to look at level of satisfaction, and then the percent that are discharged to a lower level of care. So those are important areas to look at. So that's still their plan. So now let's move on to improve. As in our assess, plan, and improve, we're at improve. So identify those interventions. And there's a little caveat here. We want to just make a quick point about not starting a PIP with an intervention and then trying to design a PIP around that. So not starting an idea with an intervention. There's a new treatment that we really would like to try. Oh, let's make that a PIP. Right. Or there's new training we'd really like to try. Well, we should make that a PIP. And that's not really how this is supposed to work. We want to bring you back to the idea that we're looking at consumer and client outcomes. How does it improve consumers and clients? If that new treatment is set up to improve an outcome for the consumers and clients, then that in and of itself is an intervention, but you need to identify what the problem is for clients to start with. And that treatment will then be measured to improve it. But having an idea that we have a new treatment,
yes,
and now we want to start a PIP is not the way that this should work.
And so one example that recently came up is a county had youth with both mental health and substance use issues, but they were dropping out of treatment a lot, and they needed to really look at the fact that none of the staff had any training or program expertise in the substance abuse side. So they did some research on best practices for youth, found a module from the Seeking Safety program, and trained staff to be able to do it. And the dropout rate really improved. And they were starting with 1 or 2 clinics, as Amy was saying, and then going to spread it out to their contract agencies and others as they saw whether or not it was successful. And that kind of approach is very systematic. They identified the problem. They didn't just say one day, gee, I wonder if we could do Seeking Safety modules. They really reached out to the intervention after looking at their data and looking at a problem that they had identified.
So that would be what we would expect, is that you decide to improve an issue and then put the intervention into place.
Right.
So, and as soon as that intervention is put into place,
ta-da!
A PIP has started. It's hilarious.
It is active.
Yes, it is.
Yes.
So to continue our example, we just wanted to give you the slides here that showed the interventions that they put together. In this particular example, they did list hiring additional staff to create the community care team as an intervention. Of course, that was not when the PIP started. Hiring the staff was not when the PIP started. It started when they did the outreach that you see in number 3, and they provided the engagement services. And when they started documenting those engagement services and that were provided prior to the first appointment. So you'll see also that one of the things that this particular table shows you is the barriers and the causes that each of these interventions addressed. And I think that's important when you're looking at the full picture of a performance improvement project. You know, in this particular performance improvement project, they wanted to increase engagement, and they wanted to increase the capacity. And so they've sort of defined for you and shown you how each of those interventions relate to those. On the next slide, they talked about increasing medical staff hours at each of the different clinics, and then they talked about increasing documentation and assisting clients to transition to a PCP. So these are some of the areas that they had identified that were issues. So again, when in this scenario, we're looking at the idea of continuous quality improvement. They assess the problem, they planned for the problem, and then they put into place the interventions to improve the problem. And visit our website and look at this particular PIP to see the effect that they had on that particular problem, because this is one of the PIPs that was successful. And we've kind of left that information off here for you on purpose so that you go out there and investigate what PIPs are out there in that library, and you can see what you can do there. And please contact Behavioral Health Concepts. You can see the number on this slide where you can get more information about this. And if you have any questions, concerns, or want to talk to a reviewer about your particular issues in your county, be sure to call us at that number or send us an email. Yes. Thank you for your time. We appreciate you listening and watching our video.
Thank you.